Welcome, everybody. Thank you so much for joining us today. I'm Amanda Dyer, the co-director and producer of the documentary film Unseen: How We're Feeling Parent Caregivers and Why It Matters. The film explores the challenges faced by many parents who are caring for children with disabilities and complex medical needs, which is estimated to be 16.8 million people in the United States. And in recognition of National Family Caregivers Month this November, we're hosting a virtual screening event where the film is available to stream on demand from November 18th through 30th. And you can get more info and tickets at caregiverdoc.com/November. And if you're watching at a later date after this, we also have screenings coming up all the time, both in person and virtual. So if you go to caregiverdoc.com/watch, you can keep an eye on those upcoming screenings. And then now we are excited to present a series of webinars and panels discussing resources that are possible solutions to some of the challenges that are explored in the film. So today we're going to be talking about one of those possible solutions, the Family CNA Program. We'll be exploring what exactly the program is, how it helps family caregivers, and how it can benefit states as well. So we are here with Fred Johnson and Bill Sczepanski. Hopefully I said that right. Okay.
Yes.
Great. Fred is the president and CEO at Team Select Home Care, and Bill is the vice president of government relations at Team Select. And Team Select is an agency that administers the Family CNA program to families in 5 states across the U.S. So Bill and Fred, thank you guys so much for joining us today.
Yeah, thanks so much for having us, Amanda. Super exciting and really neat to see all the people on the chat room and where everybody's from.
Yeah, so much interest in this program. And I'll let you guys, if you want to do more introduction about your role with Team Select and more about what Team Select does, I think that would be a great start.
Sure. I'll kick that off. I think everybody understands the role I have. But what Team Select is, we are a national home health provider, a home care agency. We provide skilled care primarily to pediatric long-term care clients. I think we'll talk about kind of the patient population in a little bit, but we have, I think we're getting close to about 50 offices across 11 states. And primarily we provide home nursing and therapy services to medically fragile children, and then some adults as well. And our goal is to keep those children safe at home with their families and out of expensive institutional and hospital settings. We do also have about 10% of our business is a Medicare home health business and mobile physician business that we do in Arizona and Colorado, but primarily we're a long-term care pediatric skilled business. Bill, you want to
Good morning, good afternoon, everybody. I'm Bill Sczepanski. I'm the Vice President of Government Relations here for Team Select, so I handle all of our government affairs and also working on the Family CNA program, bringing it to more states. I've been in the home care industry for about 20 years now, most of that time as an administrator. So I've been also been on the front lines and seen what our families and our nurses and caregivers have to go through on a daily basis as well. So I'm really glad to be here to talk about this different model.
So to kick things off, one of the recurring themes that we have heard from parent caregivers during the making of the film is really this shortage of private duty nurses. So they have a child at home that requires 24/7 medical attention or supervision at all times. And that's a serious place to be. So could you describe some of those conditions that a medically fragile child would have, or the type of medical care they would need, just so people understand, like, what's the situation that you're able to address?
Yeah, exactly. So generally, we're talking about anywhere from 0.5% to a little more than 1% of the pediatric population would be defined as medically complex or medically fragile. Usually, there's a chronic debilitating condition or multiple conditions. They generally meet a couple criteria. One of the most common is technology dependent. In order to sustain life and health sustaining factors, there's a need for feeding tubes, oxygen and ventilator support, IV therapy. Another common characteristic is, complex medication regimens and frequent medical interventions in order to sustain and maintain health status. There's generally a strong need for ongoing assessment and interventions by skilled nurses, or as we'll talk about in a minute here, trained nurse aides. And then generally most of these children, if home care wasn't an option, if we couldn't safely and effectively care for these kids at home, the vast majority of them would probably be in a hospital or long-term care skilled nursing facility. Some of the examples of conditions we're talking about would be cerebral palsy, cystic fibrosis, pulmonary dysplasia, congenital heart disease, muscular dystrophy, fetal alcohol syndrome. The unfortunate piece is for most of these children, it's not a curable condition. What we're doing is trying to keep them safe at home so they can develop with their families and siblings and try to live as normal a life as possible and keep them safe at home, with their families in the lowest cost setting and out of hospitalizations and keep those beds free for children that really need them.
Mm-hmm. Okay, so what I'm hearing is if they can't safely receive their care at home, then that likely means they're hospitalized or in some other kind of care facility, not.
Yeah, exactly. I can expand a little bit on that. The effects of the nursing shortage. So clearly, unfortunately, due to the nursing shortage that existed before the pandemic and then was really exacerbated during the pandemic, it's unfortunately very common for these families to be without care more than they have the care. Most children are authorized, depending on acuity level, for as few as 8 and as many as 24 hours a day of skilled nursing in the home. And it varies by state, but I've seen anywhere from as low as only in certain states, only 18% of the authorized hours that these children and parents are entitled to receive actually get filled. And then some of the best numbers I've seen is about 50% of the hours that these parents and children need to rely upon to stay safe at home and out of these expensive settings go unfilled due to the national nursing shortage. Due to the Medicaid reimbursement dynamics for this type of care, it's pretty much 100% of the time in every state, hospitals and other settings can pay significantly more for nurses. And so that makes it extra difficult to make sure that these kids get the care that they need. I will say, though, that even if there was high enough rates where companies could attract more nurses from hospitals and other settings, the reality is all we're doing is shifting valuable nurses from one setting to another. At the end of the day, rate increases help, but at the end of the day, there really needs to be, a smarter, more innovative way to care for these children that doesn't rely on a limited asset. And then, how that affects the parents and the children when there isn't the consistent nursing care is several different ways. It's almost impossible for parents, especially when the divorce rate for parents of medically fragile children is extremely high due to the physical stress, the emotional stress, the lack of sleep. The difficulty, it leads to an extreme difficulty for parents or single parents to maintain income outside of the home. Generally, most of these parents, they're every bit as talented, educated, hardworking as any of us on this call, but through no fault of their own, due to the nursing shortage and lack of consistent nursing in the home, they're really left with only two choices. The most common is they're forced to leave the workforce, either voluntarily or involuntarily. When less than half their shifts get filled, they're calling in sick to work half the time or more, and that just doesn't work. So then oftentimes they end up on government assistance. The other alternative, which is frankly just as bad, is they have to check their child in, to a children's hospital or long-term care skilled nursing facility until consistent nursing can be found. That's obviously terrible on the developmental mental and physical development of a child to grow up in a hospital or skilled nursing facility compared to home. But it also has the unintended effect of significantly driving up the total cost of care. When these children are in the hospital, filling up beds, the average child before the pandemic spent an extra 56 days in the hospital from a national study, unable to discharge only because of home health nursing couldn't be found. And states are paying $3,000 to $5,000 a day for that, instead of implementing a model like this that can drive a 90% reduction in those hospitalizations, which I'm sure we'll talk to in a minute, and keep these kids safe at home.
Not to mention the family trauma of having your child in the hospital, when it feels like it's not even necessary. Yeah,
exactly.
And then one point you mentioned about the wages, I do hear a lot of people just, in these conversations that we have around this topic, that it seems like, oh, it's just a wage issue, that if they were paid more for home health, that would solve the problem. But you're saying that might help, but that in itself is not solely a solution.
Exactly. Yeah. If you'd like, I can kind of go into how this program really helps address that. And how the Family CNA program can actually work to address that problem, and for a portion of these families and children really eliminate that labor cost, that labor issue, and do it at a significantly lower cost. But yeah, you're absolutely right. I mean, rate increases are definitely needed to keep pace with what hospitals and travel nurses, et cetera, have been able to make, and how that's blown up through the pandemic. But yes, without innovative solutions like this, where we're looking to expand the workforce, rate increases alone will only help to shift nurses from one setting to another, and we'll get more in home health, but then we'll create a bigger gap in hospitals. So it's really, this kind of innovation is needed. So, with this program, there is no silver bullet solution for this, but far and away, in my decade in this business, and Bill's even longer than that, there's no question that this is by far the most innovative, common sense, and practical and impactful solution that this industry has ever seen. This program's been going on for over 20 years in Colorado, very successfully, with amazing cost reduction results and improvements in the outcomes of these children. It's expanded to 4 more states. Arizona, New Hampshire are following the Colorado model, and then Indiana and Pennsylvania have recently come live as well. And it's similar to the Colorado and New Hampshire and Arizona model. It just means there's certain skilled tasks that can't be delegated yet that we have to work with the Board of Nursing on. But these programs are up and live and having a big effect already. And so basically how it works is,
let's get give us the big picture. Kind of, someone's coming in and doesn't know anything about this program.
Right.
How do you describe it?
Yeah. So, basically now, for a medically fragile child, whether it's 8 hours a day or 24 hours a day, the vast majority of a care plan that a nurse is performing are low acuity duties, such as bathing, bed transferring, activities of daily living, tube feeds, etc. And so what happens now, due to this federal definition of PDN, is that only nurses—
Can you define that?
I'm sorry, private duty nursing. Yeah. Okay. So what we call when we take care of these kids in the home, PDN, private duty nursing. Okay. And so Medicaid and Medicare define that as RN or LPN care. We've been successful in, 5, kind of 6 states now in helping change that in those states so that we can use nurse aides. And so basically what happens is, a nurse right now working an 8-hour shift may only spend 30 minutes doing trach and vent high acuity work that should really be done by a nurse, not a nurse aide. And then the rest of the 7.5 hours or more is all dedicated to lower acuity duties, like I mentioned. So what happens with this program is just pure common sense, and it happens in every other setting for every other type of patient. The way that we do it is we take the appropriate parents. Not every parent is perfect, and we can use family members too, other family members. In these 5 states, we identify those eligible patients and family members, and if appropriate for them, and if they're the right kind of person to do this care, we train them for free with no strings attached to become a nurse aide. In Colorado, they use the CNA, Certified Nursing Aide designation. In Arizona, it's called a licensed health aide. In New Hampshire, it's called a licensed nursing aide, but all basically the same thing. Usually about 80 hours of classroom, 40 hours of clinical, then a bunch of onboarding and testing. And so we pay for all that with no charge and no strings attached to the parents. Once they graduate, then we help them get certified through the Board of Nursing. So they get certified completely and licensed through the Board of Nursing. Then we take them through our orientation process, and we actually hire them as a W-2 normal employee, just like we would hire any other nurse in the company. And they get paid to take on those lower acuity duties for the children that they know best, which then the state gets savings because we are able to do that at a lower reimbursement rate by using nurse aides rather than nurses. We free up our valuable and scarce nurses to work on the highest acuity trach and vent type children, also become case managers, clinical supervisors, directors of nursing. So basically, we free up the valuable nurses to work on higher acuity cases where they're needed, and we take the low acuity duties and have them performed by a family member or a parent in this case. Important to note that parents are not paid to be parents in this model. They are only paid to perform duties that were previously only being performed by a nurse and specifically authorized by a physician and Medicaid. The results that we see from this program are utterly staggering. What we've learned with years of data that we have now over thousands of children is that it's not necessarily the level of care that these children receive, whether you send in, an RN, an LPN, or a nurse aide. What matters is, a medically fragile child that's authorized for home care is highly acute, yes, but they're stable. And in order to stay stable, they need their trach cleaned and suctioned every day. They need their bowel care so they don't get an infection. They need their tube feeds for proper nutrition, et cetera. And when somebody is there to execute that care plan every day without fail, that also knows that children better than any nurse ever will and knows what to look for, has tons of support and technology and tools and clinical oversight, what we see is over thousands of children, over a 90% reduction in the unplanned hospitalizations of these children when we use this program versus the national average. So the national average 30-day hospitalization rate for medically fragile children is 18 to 21%. That means every 30 days, a child that's medically fragile enters the hospital 18 to 21% of the time. Through our program, over 2,000 children over multiple years, our hospitalization rate is 0.7% for the same children. So we're driving over a 90% reduction in the unplanned hospitalizations of these children. And when you consider that, 50% of the total cost of care for these children is hospitalizations, and we're able to reduce that by over 90%, we're saving Medicaid in the states 45% on the total cost of care for these children, while freeing up hospital beds, getting parents off of food stamps and welfare and giving them a benefits package, freeing up beds, valuable hospital beds for children that desperately need it. So again, it's really that the continuity of the care that people have to get their minds wrapped around, and not necessarily the level of care, is what makes the huge difference in this program.
Mm-hmm. Yeah, and to your point about parents taking on these, well, when there is the shortage, they're not able to get these care hours covered already. It's, from what we hear, families are already performing these tasks. They maybe just haven't gotten the training or don't have all the tools that they really could use.
Exactly.
So this is, it's taking, they're already doing it. It's just turning it into, now they can actually have some economic reward as well.
Exactly.
Which is challenging because, if you had to leave your job because you need to provide these services, you're really stuck.
Right. I mean, this gives parents their independence back. In most cases, we're able to provide a stable income. If they work more than 30 hours a week, we give them and their entire family a full benefits package, really give them their dignity and control of their life back in as much as we can.
Mm-hmm. Yeah. And I know we talked to many caregivers who want to be the caregiver. Like, they, like you said, they know their child, they are confident they're going to be providing that really high quality care. So it's really an ideal situation. Maybe not for every family, but for a lot.
Yeah.
Yeah. All right. So tell us a little bit about how families qualify for the program.
Yeah, I'm sorry. I was doing the chat, so answering all the awesome questions that are coming through.
And we can bring some of those questions into this conversation as well.
So sorry about that. I got a little distracted.
You're fine.
Actually, I just wanted to answer a question that came about what Fred was saying in one of the chats here that I was just answering was about how do you limit burnout with the families through this model, and that's a great question. So we do not limit how many individuals go through this program. So, as Fred was saying, it could be a family member. In some states, it could be like a friend that you allow. It's really who does the family want to come into their home to help care for their child, for their baby, and that they feel comfortable with. And so what that being said is that we can then build a care team around the family to help them. So yes, mom or dad may be providing 40 hours a week of care, but there could be other individuals who are providing care on the weekends. So you can go to like Costco, things like that. And so it kind of, in a sense, builds in that respite, but also builds in that care team, which really is what private duty nursing is supposed to do, is have a team of nurses to help care for your child. So that's how we keep from any type of burnout to occur.
Okay, so you're not limited to only like one parent or one family member that can be the certified. Okay.
Correct. Yeah, we don't limit it. And then, as Fred said, there's no strings attached. So if you work for us and then decide you want to switch agencies, that's your choice. And there's no strings attached, no paying back to any of the education or anything like that. So that's what's also really nice about it. And then how families qualify for this program is typically it's individuals who already are qualified for private duty nursing. So individuals who have anywhere from a feeding tube up to trach or ventilator needs. And basically in Colorado, how they qualify is that we go out as the agency, our RN case manager goes out and uses what's called a pediatric assessment tool. And it uses a thing called Iowa stages and phases. So what that means is that if a child is 10 years old and they can't bathe or feed themselves, you're no longer being a parent, you're being a caregiver. And so it shows not only their needs medically, but it also shows how many hours they should qualify for. We then send in information to the doctor for them to sign off on, and then we send it into Medicaid for their approval. So then we can go ahead and start getting the families through the CNA program there. And so every state is a little different. That's one thing I do have to just kind of put like as a caveat. So that is the challenge when you speak about this program nationally, is that every program is a little different. So there's little tweaks here and there and nuances that you have to deal with. But for the most part, that's how it works in most states.
And currently it's only for 21 and younger, I think you said?
Correct. It's only for 21 and younger at this time, because then when they get over the age of 21, you're dealing with a different programs and different waivers that have different rules and regulations that you deal with. Typically with children, because as Fred was saying, under EPSDT, which is the federal regulation that oversees programs for kids who are on Medicaid. It gives much more flexibilities to allow for different things than for adults.
Is there any plans for it to be extended, or is that on the horizon at all? Because I mean, we hear that constantly, is that it's so hard, especially when other services go away.
Sure. So eventually, yes. For it to really be fully effective for adults under the HCBS waivers, the home and community-based service waivers, there's right now a prohibition federally under most of those waivers that does not allow a parent to be, or parent, spouse, or guardian, as it says in the law, to be a paid caregiver. And so organizations like Team Select, we are working on to try to get that change with CMS in order for that to be repealed so that can be allowed. And we're starting to see movement after COVID. One thing COVID has done is it has hurt us in regards to the nursing shortage and workforce shortage, but it's also opened CMS's eyes to things that need to be changed. And so our hope is in the years to come, these things are going to evolve where it will change. And as we know, working with the feds, unfortunately, is a little slow to change, but hopefully will be coming.
Do you think some of that is because of this idea that we shouldn't pay people to be parents? Like, is that kind of the mentality behind it?
Especially, so there are some programs already for adults that are out there that you see, but this program is more medically based and then overseen by an agency, and then also to your point, you said a lot of people, I don't want to pay a parent to be a parent, and that's where we talk about using tools like the pediatric assessment tool that was developed in Colorado, because it shows you're not paying a parent to be a parent when you're asking a parent to feed and bathe an individual and move them around. That's no longer being a parent, that's being a caregiver. So it's just, we started this about 5 years ago, and I'm working on this because we have been working now in Colorado for almost 10 years under this program. About 5 years ago, we said, why aren't we doing this elsewhere? And so we started looking at our states and working on this. And when this first happened, Fred and I, when we were going to states, that was probably the biggest thing that we heard. But as we have educated individuals, and this has come out here to become more mainstream as an idea, that has really gone away. We see that less and less now, where especially legislators are like, no, we're not paying parents to be parents. They're caregivers. So just the difference that we're talking between pediatric and adults is age. It's still the same.
The needs don't change magically just because you're 1 year older. Yeah.
Correct. Yes.
Yeah. And that was one of the goals we had with the film too, is to show that there is a big difference in being a parent and being a parent caregiver. But it's common for us to hear that families say even their family and friends don't understand that, just because it happens at home. You don't always kind of see behind the curtain. And so family and friends don't know, policymakers are not going to know. Right. So that was one step toward the film, was first opening people's eyes to the fact that there's a lot more to caregiving than you might think on the surface.
Yeah, we're really excited to have the film at our disposal. The 10-minute clip and things. Bill's been using that a lot to educate legislators who need a better understanding of this. So I really think the Unseen documentary is going to help accelerate our progress and bring this program to more states going forward. So can't thank you enough for that.
Yeah, we're really excited that it can be used in that really tangible way.
Yeah.
And then that actually, just in the chat here, Cindy just asked that question: how do we get legislators to recognize caregiving as not parenting? And that's one way where we are doing that, Cindy, is we are utilizing this film to educate legislators so they can see, because obviously not everyone has had exposure to our community and knows what's going on day to day. And so with that being said, by showing them this video, this really opens their eyes, and those barriers come down immediately when we show that. So this is great. Having a documentary like this really helps with that. And then one other thing I was just wanting to say, Christine had asked a question about behavioral needs. So Christine, in most states, this is for individuals who qualify for private duty nursing. In Colorado, they have expanded the benefit. Again, they've been doing this for 20 years, so they've expanded to individuals, for example, who are on like the spectrum or have severe behavioral needs, where this has become an option for those families as well. So one thing I always tell everyone when we start a program like this is you usually start at one point and then it will expand in time. It just has to grow and evolve. Because in Colorado, this program started with only one mother who wanted to do this, and she went ahead and appealed it all the way up to the Medicaid director, and that's how it started. And then it slowly evolved from there. So every state, we started at kind of a starting point, and then we kind of go from there and evolve it. So there are those options out there.
Mm-hmm. So is the strategy then to really try to, in states so far, to start with the kind of the model that you have in Colorado that's been really effective? You can prove it, you have the data to show it. And then that really, once that's in place, that opens the door to allowing other, getting rid of some of these legislative restrictions that limit it, and then opening it to more behavioral needs outside of just medical complexity.
Yes, correct.
So kind of a
correct. Yes. And it's from Medicaid standpoint, they are used to people coming in daily telling them how they can save money, and we have this program, we can save you money in that. So we really have to prove it out and show them how it works and how it's going to work in their state. And then once we can do that, then yes, then we have a lot more flexibilities to expand and to look at different other options with this model.
Mm-hmm. Yeah, once you see the power of it and it being effective, it's a much easier conversation to take it to the next step. Yeah. Could you recap real quick kind of the states that have it or have a modified version of it? I know we had a couple of questions about that.
Absolutely. So currently right now, so Colorado is the longest. It's been around for over 20 years now. New Hampshire has been doing it for about 15 years. Arizona actually just implemented the model in the spring of this year. So they're now fully in Pennsylvania and Indiana. They have the model, but a modified version of that model. So we're limited to, we cannot delegate certain skill tasks under that model. And then California also has this model, but it's limited because it's only to regional centers. And so it's very limited population, and they also do not allow for delegation at this time. But we are working in other states to bring this in other states. So currently we have legislation pending in New Jersey currently right now to bring this model. We will have legislation next year during their session in Texas and in Florida to bring this model. And then we're talking to several states right now about this model who are highly considering. One is Washington State. We're also looking at Massachusetts as well, and Virginia.
Excellent. And so you've kind of hit on this a little bit, but just to pull it all together, what are the barriers in states right now from this program being in place?
Sure, absolutely. So typically the barriers, are usually, and there are some states like Colorado and New Hampshire where they could just go ahead and do the program. There was nothing that limited them from doing it, and nothing that said they couldn't, so they went ahead and did. There's in a lot of states, there are prohibition of keeping parents from being paid caregivers. And so in order to remove that regulation, Medicaid requires us to go to the legislature to get their approval to remove that regulation. So that's usually the main barrier that we see. And so that's the reason why we usually have to go the legislative route to look at it and see. There was a question also in the chat, just what do we mean by delegation? That's a great question. So when we talk about delegation, there are certain what we call skill tasks, like doing a G-tube or gastrostomy feeding, or Mickey button feeding, tube feeding, or if you're doing trach care, those are considered skill tasks. And so a nurse, an RN, has to delegate that task to an aide. And in most states, that is, you are allowed to delegate those tasks as long as the aide, as long as the nurse feels that the aide is competent to do that task and checks them off annually to do that. So that's when we're talking about delegating tasks. So delegating basically some of the nursing skill tasks that they would do.
And so Team Select can help with that, making sure that the parent or with the CNA certification can competently perform those tasks in a way to be compliant.
Correct. So correct. Just how we normally go ahead and we check off a nurse every time they work in someone's case to make sure they know the tasks that they're supposed to be performing per the plan of care. We do the same for aides as well, and making sure that they can perform the tasks as the plan of care has been written by the physician. And then it also too, there was a question here in the chat about how can we help support that's a great question. Please feel free to reach out to us, and we will give our website information again at the end of the session. But we always are looking for individuals to help talk to legislators through Zoom chats like this. A lot of legislators love doing that now, post-COVID. And so it really gives the legislators a chance to understand what's going on in your home and the needs that are going unmet for you and your child. So that's great, and we love being able to set those up. And then also too, if you're interested in a state that maybe I didn't mention, and you would like to know more about that, please feel free to reach out to us through the website. I will get your information and I will reach out to you, and we can discuss kind of the situation in your state as well.
Mm-hmm. Yeah, I think that's exciting because it can be intimidating. Like, how do I get a law change in my state? Or, it seems like a really big task. But, you guys have done this, your experience, you can help guide it. And a lot of times the first step is really just as simple as sharing your story and making sure that the people making these decisions understand the situation that they're making decisions about. So that's cool. It's just kind of and so it starts with reaching out to you, and I think you have some website addresses in the chat there, and we'll also share it on our website and things too if you want to check that later, so you have access to it.
Great.
Go ahead, Bill.
No, I was just going to say I agree. I think that the biggest thing that I have learned through my time as being in government relations is your story. Your story means a lot to legislators. I mean, the numbers and the facts and the figures, that's great, but what makes this go and what will make this get implemented is legislators remembering those stories, because they remember them. They remember, hey, I spoke to this mom and I heard a story and I heard the struggle she's going through and her child, and I want to help them. And so those stories are so powerful. No matter how much data we give to them and that and facts and figures, the stories are huge.
Mm-hmm. Yeah, just human nature to be able to you remember a face in the story more easily than all the numbers in the world. So it's very compelling when caregivers are brave to go and share their story and be honest about it. So one other thing, again, we've touched on a little bit when I want to bring it all together is, you may hear about this and think like, well, no wonder states don't want to do this. Sounds like it'd be really expensive. You're suddenly paying way more way more money going out the door to caregivers. What you say this program helps save the state money? How does that work? Can you explain that to us?
Yeah, I'll take that one. And Bill, if I miss anything, so multiple ways. The first way is in order to reimburse, states pay based on kind of education and salary levels. So they'll pay a home health agency like us generally more dollars per hour to staff an RN, then they'll pay a little bit less to staff a licensed practical or licensed vocational nurse. And then, clearly they'll pay less for us to staff a nurse aide. So generally what we see is, anywhere between 20%, sometimes close to 50% lower reimbursement rate that the states need to pay agencies like Team Select per hour to staff a nurse aide instead of, say an RN. So they get savings of, 20 to maybe 50% per hour. To your point though, Amanda, there generally is going to be some slight offsetting and an increase in utilization. Certain now, if the state say is only covering 18% of the hours that are authorized, and then through this program, we're able to double it from 18% to 45% or higher or something. that 20 to 50% savings per hour can get eaten up a little bit with the higher utilization. So it's possible that there could be a little bit more money going out the door. However, when the home health is generally a couple $100s a day, compared to the hospitals being, at a low end of 3,000, maybe a high end of $5,000 a day. And even, before the pandemic, like I mentioned, national studies saying the average child spends 56 extra days in the hospital unable to discharge because there's not nurses to take care of that child at home. This program helps get those kids out of the hospital faster, takes that 56 days down to something much more reasonable. And then the dramatic over 90% reductions, the difference between the 18 to 21% national average and our 0.7% 30-day hospitalization rate for these children represents a greater than 90% cost reduction on the unnecessary hospitalizations. And since that represents almost half the total cost of care, when we can reduce that, half the cost by 90% or more, that's tens of millions, if not hundreds of millions of dollars of savings for states that can then go to other desperately needed, medical situations, reduce taxes, whatever, you name it. But generally, between the combination of those two, when you take the all-in total cost of care for these children, we're talking, probably a 40% reduction or more in their total cost of care. And then, one thing to remember about these children is they generally make up about 1% of Medicaid's pediatric population, but anywhere between 33 to 40% of the total cost. So generally these children unfortunately cost 33 to 40 times higher than a non-medically fragile child. So when we're reducing, 40% of the total cost of care by close to another 40%, the savings are just immense and dramatic. And, at the same time, we're getting a lot of parents off of government assistance by giving them, full-time work. If they work more than 30 hours a week, they get the same executive benefits package that I'm on. It's real insurance. It's not one of those programs meant to provide as little coverage as possible and still meet the requirements of the law. This is real healthcare, not just for that parent or caregiver, but for their entire family as well. So we're able to drive lower utilization of government assistance as well.
Mm-hmm. Well, and I keep thinking too that it's great to talk about it in the dollars and cents of it, but also just to avoid again the trauma and family impacts of having your child in the hospital. Like that can't even be quantified in dollars, and not how do you take care of your other kids when you have one in the hospital? Both, if there's two parents they're both having to be off. I mean, there's just so many layers to this that aren't even represented in just the facts of it.
Exactly. So for a lot of parents, that have multiple children, a similar model might be that parent needs to spend more time with their other children. It's why that we use so many family members, and sometimes it's neighbors and friends. Like we've kind of started calling it the bring your own caregiver model in some respects too, because if it's only the parent in the mix, then they're providing that daily care for their medically fragile child, but it still doesn't help these other siblings who tend to get ignored sometimes and not get the attention that they need and deserve to be able to grow up and develop emotionally and mentally. So sometimes it really makes sense to train another caregiver, a sibling, a parent, an aunt, an uncle, that can come in and provide some of that care, so that parent can spend more time being a parent for their other children and can go out shopping and try to get that respite that they so desperately need. And just I've seen it a little bit in the chats, and I think Bill's more qualified than me to comment on this, but there are states where you don't necessarily, your child doesn't necessarily have to be deemed medically fragile and qualify for private duty nursing in order to leverage elements of this model. Like in Indiana, in like 3 months, we developed a census that's approaching 200 now, because we're able to do it for lower skilled children as well as adults. So the program is taking off there like wildfire. And a lot of states have more unskilled programs that's built under the home and community-based services regulations, where Bill mentions a lot of states will have a prohibition against a parent being that unskilled caregiver for that child. But there are no prohibitions in most states against, the only prohibition is against the parent or a legal guardian that lives with the child. There's not necessarily a prohibition against grandmas, grandpas, aunts, uncles, neighbors that are greatly trusted. And so it's maybe, not quite as perfect as using a parent who knows that child intimately and never misses a shift, but it can be pretty darn close to that. And so that's another way and that's what we're calling the bring your own caregiver model. Mm-hmm. And we're actually working with a lot of what we call MCOs, managed care organizations that kind of manage the Medicaid benefit. And they've been approaching us left and right saying, hey, we're all for this Family CNA program. We're helping support your legislation in Texas and Florida and New Jersey, but it's going to take a minute to implement. In the meantime, why can't we just do the program, but use non-parents and direct legal guardians that live with the child up until the point where the legislation is enacted? So that's another big, area that we're just starting to put the gas pedal down on in order to bring care for, not just children that qualify for private duty nursing only, but also those children that have lower skilled care needs, and it's not practical to wait for the legislation to be implemented. We have a little bit of an in-between model that we're going to try to do very aggressively and spread as much as we can nationally to bring more care to more children and families.
Cool. And yeah, that opens up the door for at least using those as respite hours, or right, doing other things you need to do, and I know it would be a relief, and a lot of times to have a trust someone you already trust being the person to come in, be in your home, be around all day. So I think that's a benefit in a lot of cases.
Yeah.
All right. Is there any other topics you guys wanted to cover or that we didn't address? I think we hit on most of the questions. Oh, there was one about when you do the training for parents or caregivers, does that have to be in person, or are there online options? How does that work?
Yeah, so it varies by state. The nursing board, we work with the nursing board to set those rules. Colorado, you have to become a certified nursing assistant. It's 80 hours of classroom and another 40 of clinical, and then a bunch of onboarding. We are able to offer a good portion of that in Colorado to be online learning now. That wasn't the case, before the pandemic, but the pandemic caused us to be more innovative and allow these parents to stay safe at home and not contracting COVID. So there is an element of online that we can do. In Arizona, you mentioned, Amanda, that these parents are already providing this care and most likely have been since their child was born and first taken home because of the lack of consistent nursing. So in Arizona, we worked, very closely with Medicaid and the Board of Nursing to implement a more common sense solution, whereby we've got a beautiful skills lab and training facility and school attached to our office here. And we take the parents, and instead of going through all the classroom training and learning how to care for geriatric patients and things that's inevitable in CNA training, we train them directly for exactly what their child needs with their child, with their equipment. And we do it one-on-one. And we're often able to get that training done in less than a week. But that does need to be in person because it's very, very hands-on. So it'll vary by state, but clearly for any clinical competencies, we're going to have skills labs and that mimic a child's bedroom in every one of our offices that we already use to make sure our nurses can demonstrate that capacity and we can sign off on it. We do the same with parents. And of course, that will always need to be done in person, but we're always going to try to make it as easy as we can on the parents, because what we know from working with thousands of these families is getting out of the house when you don't have nursing to be educated is really hard. And for some parents, it's even impossible. So we're trying to be as creative and innovative as we can, but at the same time, we have to go by what the Board of Nursing will allow us in the given state.
Yeah, I think you're as informed as anybody about the challenges of being a caregiver of a child with complex medical needs. So trying to accommodate that as much as possible.
Yeah. Was there anything else you noticed in the chat, Bill? I'll be honest, I didn't get a chance to look too much in there.
There was actually just a question about how to qualify for this in Texas, where we're going to try to do legislation. And just to answer Stephanie's question, it would just depend to qualify for this program under the current framework that we have for legislation to get this added. And of course, it still has to be approved by the legislature this coming session. The individual would have to be qualified for private duty nursing under the STAR Kids program. So they would either have to more than likely have some kind of feeding tube, trach, in order to qualify for this care. And then there was another question about any information about this in Kansas. We're not currently working on anything in Kansas right now, but we're always open to looking at states. When we first started out with these states, honestly, we looked at the states where we had locations at and started working on that. And currently, we do not have a office in Kansas, but we're more than happy to discuss that and look at those, look at a state like Kansas.
Just in the interest of what's best for these kids and taking the business side completely out of it, Bill, I think Thrive has a couple locations in Kansas.
Correct.
And it's Thrive Pediatric Home Care. If you Google that, or maybe you're already familiar with them if you live in Kansas. They're also supporters of this program. We've locked arms with them in other states to try to create more of an army of people. So they are aware of this program. They can help too. We'll want to help you. We'll help anybody in any state, whether we're there or not. But that's who I would recommend locally trying to reach out to and encouraging, because they're supporters of it.
And there's some other names that the program goes by, aren't there? Like if people are looking in their state or looking around, what do you know what those are off the top of your head?
Sure. So it could be either called the Family CNA Program, Family Home Health Aid Program, Family LNA, like in New Hampshire, that stands for Licensed Nursing Aid. In Arizona, it's Family Licensed Health Aid. So it depends on what they call an aid in your state. And also too, to go to Fred's point, we partner with other companies actually right now to get this into other states, and we're willing to keep doing that with even more companies. But also too, we work in states right now. We're helping other states like Washington State and Virginia and Massachusetts, where we actually don't have locations, but we're wanting to help bring that to that state. So whatever we need to do to try to help bring that to that state, we would like to do so. Because again, as Fred was saying, we've been doing this now for almost 5 years. We have a lot of knowledge, and so we want to share that knowledge to get as many states up and going on this model as quickly as possible.
Mm-hmm. Yeah. All right. Sorry, go ahead, Fred.
Sorry, I apologize, Amanda. I just Cindy out there had a question on high acuity patients. Are they eligible for this program? And the answer is absolutely. In most states, as long as your child qualifies for private duty nursing, you're eligible. In cases like Arizona, where we crafted the legislation, we worked with Medicaid and the Board of Nursing. We were actually able to get it such that parents can even perform trach and ventilator care work, which is, generally about as high acuity as it gets. In places like Colorado and New Hampshire, where nurse aides can't do trach and vent work, what we'll do is, most of your high acuity patients can be for more than 8 hours a day. So maybe that child's authorized for 16 or 24 hours. What we might do is work an RN, registered nurse, or LPN shift for 8 hours and put as many of the high acuity tasks and all the daily trach and vent work in that shift. And then maybe the parent or family member as a nurse aide is checking in, 3 times a day for 2 hours to do the feeds and activities of daily living and bathing and stuff, those other care plan duties that nurses currently in most states are forced to perform well below their license level. And we'll have cases that are part, RN and LPN or LVN staffed, and then part staffed with a nurse aide as well. So we have cases that are purely nursing where the child or the parents aren't appropriate for the program. We have some that are 100% lower acuity taken care of by a nurse aide, and then a whole bunch kind of mixed.
So I think the takeaway there is it's customizable, kind of depending on the individual situation.
Exactly.
Yeah. All right. Well, we're running out of time right now. I'm excited to see there's so many questions about specific states and how do you get involved. I think the best thing is if you go to the Team Select website. We've got the link in the chat here, or actually let's say it so that we, if you don't have the chat later, it's tshc.com, right? Did I say the initials right? Okay. If you go there, that's the best place to start to find more information. That you have pages for each state so people can see what's available or what's coming down the pipeline. And then if you have specific questions of if you would qualify, you can also reach out there to have a conversation about that. And if you registered for this event, with your email address, we will send you this recording so you'll have access to it. And it's also going to be on our website, caregiverdoc.com as well. And we'll include all the links there so you can access it. Did I miss anything? Any other final recaps?
Just an enormous thank you for giving us this chance, for producing such an amazing, documentary that I think is helping us tremendously to educate more people and bring this program to more families. I can tell you all on this call, we are going to be here with you. We're going to fight for this everywhere we can. We understand what you're going through and we really care. And we're going to do everything we can to bring this program to every state in the country as fast as humanly possible.
Well, thank you all so much for being here. We're through the process of this project, the film, we of course, uncovered so many challenges that families are up against. And we're just excited to be able to see a tangible, practical solution that can really be transformative for families. So we're excited to partner with you on this.
Thanks so much, Amanda.
All right.
Thanks,
Thank
everybody.